Hey guys, it's Jake here with Med School Bootcamp. Thanks for tuning into our unit on psychotic and mood disorders. This is a really big chapter full of a lot of important stuff. We're going to start off by defining what psychosis is. This is a tricky sticking point on test day, and we're going to clear that up right away. Then we're going to go ahead and move into talking about our depressive disorders in terms of our low mood disorders. After that, we're going to go ahead and talk about mania and bipolar disorders, which are mood disorders characterized by an elevated mood. Then we're going to wrap up by talking about schizophrenia, especially its pathophysiology and some of its management. Then we're going to go ahead and do comparisons between these mood and psychotic disorders and how to differentiate them on test day, and that will be during our mood disorder comparison activity. Finally, we're going to wrap up with a discussion on suicide because these disorders tend to lend patients towards considering suicide or being at risk for suicide. So we're going to go over some suicide risk factors and how to manage a patient that could be suicidal. Now, before we continue, I want to show you guys a graph that I'm going to be using a lot throughout the unit. And this graph has two axes. It has the x-axis, which represents time. And we know that time is super important in the diagnostic criteria of our various psychological illnesses. So I really want you guys to be paying close attention to time. In our y-axis, it's all going to be about mood or energy. So higher up on the y-axis, we're going to have higher moods, close to mania, higher energies. Whereas lower on the y-axis, we're going to have lower energy states, lower moods, more depressive symptoms. And you guys will see me drawing lines that look similar to this. I'm going to go up and down, and I'm just going to move throughout as I describe each different pathology. And I want you guys to take note that this is me tracing the energy of a patient over time. Additionally, I may do overlays in a highlight of yellow. And when I highlight a specific section yellow, I'm indicating that at that point in time, a patient is experiencing psychotic symptoms. So yellow highlight over a solid line is going to represent psychosis when we're using this graph. So I want you guys to be considering all these things. And without further ado, let's get busy. All right, guys, let's get busy talking about psychosis. And psychosis is actually a fairly straightforward definition. The definition of psychosis is greater than or equal to one of the following. And those are delusions, hallucinations, or disorganized thought. So one of any of those criteria and you qualify as being psychotic. Now, psychosis can happen for a variety of reasons. Traditionally, we associate it with some sort of underlying primary psychiatric diagnosis like schizophrenia. However, it can be due to just about anything. Someone on drugs can technically be psychotic. Someone who's in the ICU and is very confused or has delirium, they can also be psychotic. So you have to get used to thinking of psychosis as a set of criteria rather than an underlying illness itself. I think of psychosis as a symptom of something else, not a disease process in itself. So I want to break down all the different parts of these qualifying criteria of psychosis. So I want to give you guys a little mnemonic, and this goes over each of the different types. So we're going to have delusions, and delusions is all about what you believe. And we'll talk a little bit about more in a second. Then we're going to have hallucinations, and hallucinations is all about what you perceive. The last thing on our list is going to be disorganized thoughts, which is all about how patients conceive their thoughts and actions. So if you can keep those things straight, believe, perceive, conceive, that's a great way to have a handle on which patients are psychotic and which ones are not. So let's go ahead and get started with our delusions. So delusions are all about what you believe. So delusions are beliefs that are not grounded in reality. So they're oftentimes strong, incorrect, and unchanging. Even if you provide contrary evidence to a patient, they still have a really firm belief. So an example of a delusion might be that the doctor is trying to put poison in my IV. Now, you can show this patient that the substance going into their IV is normal saline. You can show them the expiration date, you can show them the label, but they just have this fixed, unchangeable belief that what is going into their IV is indeed poison. So even in the presence of contrary evidence, these patients still have a fixed delusion. There are different types of delusions that you should know and be able to identify on test day. So first is delusions of persecution. So these are delusions where patients oftentimes think that someone is coming after them, someone is out to get them, someone's out to hurt them. That is an example of a delusion of persecution. We also have grandiose delusions where people think they are on top of the world. They think that they are the president of the United States. They think they are an all-powerful being. They think they are a religious figure. These are common examples. We also have somatic delusions, which are going to be delusions in which patients believe something is off or strange about their own body. We can have examples of erotomaniac delusions, where the delusions of these patients are usually related to romance or sex. There are referential delusions as well, where the patients are going to be referring to something or environment. This is oftentimes described as the radio or the television set, where they think that people on the radio or the TV are like breaking the fourth wall and physically talking to them. That's an example of a referential delusion. And the last is going to be a delusion of control, where patients are believing that someone is either trying to control them or they have the right to control somebody else as if it is their duty. So these are all examples of delusions. Now, I want to make one caveat about delusions, is that in order for it to be a delusion, it has to be culturally appropriate. So for instance, if you come from a culture where it's appropriate to believe that God will punish you for misbehaving, that is not considered a delusion because it is a culturally appropriate response. So that's a key part to think about when it comes to delusion. So now that we've talked about delusions, let's go ahead and move on to our hallucinations. So hallucinations are all about what we perceive. And so they are perceptions in the absence of corresponding external stimuli. Now that's a complicated definition, and basically what it boils down to is you think something is happening with your five senses, but it's actually not happening. And it can be in any of your five senses. So we have auditory, visual, tactile, olfactory. These are all examples of hallucinations. Now, I want to drill down specifically how each of these tends to present. So in auditory hallucinations, these are usually due to primary psychiatric illness, i.e. schizophrenia is a great example. In terms of our visual hallucinations, these are usually due to a medical illness, so be on the lookout for delirium or drugs or long ICU stays, some sort of underlying electrolyte imbalance. Those could cause visual. Now, in terms of tactile, I want you guys to be thinking about cocaine and alcohol withdrawal. Those are what's going to be causing tactile delusions classically on exam. Now, in terms of olfactory and gustatory, this is classically going to be for temporal lobe epilepsy, and they classically describe this as smelling or tasting a burning rubber scent or taste. Now, lastly, I want to mention hypnagogic and hypnopompic hallucinations. These are classically associated with narcolepsy. Hypnagogic happen right before patients are about to fall asleep, and hypnopompic occur as patients are waking up. That's something to be thinking about if you have a patient presenting with narcolepsy, fatigue, tiredness. That's an example of that type of hallucination. Now, it's important that we separate our hallucinations from illusions. And I think of illusions as when we just misinterpret sensory information. And a great example is like when you hear your door squeaking in your house and you think, oh my God, that could be an intruder. When you go and check, there's no intruder there. And that's just your brain kind of processing that sensory information as a possibility of intrusion. A true hallucination would be you're hearing a squeaky sound, but there is no squeaky sound in your environment, but you're hearing that in your mind. So you think that you're actually hearing squeaky sounds when they don't actually exist. That would be a true hallucination. Lastly, let's talk about disorganized thought, which is all about how we conceive. And this is how we take our beliefs and how we take our sensory inputs and we communicate them and take action in the world around us. So patients with psychosis are going to have disorganized thought and disorganized action. And some examples of this I want to provide are poverty of content. So this is when people are trying to explain themselves, but they just can't find the words, they can't find the proper logic to explain a meaningful thought. That's poverty of content. Next, we have tangential speech. And tangential speech is when patients immediately change the subject and are not able to stay on task. So if you're having a conversation about automobiles, a patient may quickly change the subject and go off on a tangent talking about makeup. That's just an example. Next, we have word salad. And word salad is just going to be when patients mix together a bunch of words and it makes absolutely no sense. And finally, we have preservation. And preservation is going to be when patients cannot leave a specific topic. So they just want to talk about one thing over and over. And even when you change the subject, they're going to bring their way back to that original thought. And that is an example of preservation. So just remember, when it comes to psychosis, you only need one of the following criteria: a delusion, which is what you believe, a hallucination, which is what you perceive, and then disorganized thought, which is how you conceive. And remember, when we're talking about psychosis in this unit, I'm going to be drawing lines on this graph, and anytime I highlight yellow over a portion of the line, that's going to be representing a point in time when the patient is exhibiting symptoms that qualify them for psychosis.